Ciao Sébastien.
Dear colleagues, it's my pleasure to welcome you again for this school-based webinar dedicated to tuberculum sellae meningiomas. Again, this monthly seminar will be well attended. You were more than 600 to register to listen a panel list of famous speakers on these topics. I'm truly happy that you enjoyed our webinar and you participate so actively. If you would like to ask questions, please use the Q&A button and we will try to answer your question at the end of this webinar. As you can see today, the program is extremely interesting. The first speaker, Professor Daniel Roy from Lausanne, will speak about the surgical anatomy of tuberculum sellae meningioma and the controversies in their management. Then Luigi Caballo and Professor Capabianca, who is present with us this evening, will discuss about endonasal route for tuberculum sellae meningiomas. I will speak about transcranial approach, and then Sébastien Fröhlich from Paris will speak about the transcranial versus endoscopic approaches. And finally, Henri Schröder from Greifswald will discuss with us the decision-making process in those lesions. I hope that you will find this webinar very interesting, and I will give the floor first to Daniel Roy. Please, Daniel. Up to you.
Yep, just 1 second. I'm just trying to share my screen. Can you see my screen?
Yes.
Okay. Thank you, Mikhail, and all the friends and the panelists for giving me this opportunity. And Mikhail asked me to talk on tuberculum sellae meningioma, the surgical anatomy, and the controversies which we discussed as part of the ENS skull-base committee and came out with the consensus recommendations last year. So I have no disclosures. So when we start looking at the anatomy of this region, this is essentially the middle part of the anterior skull base and the middle fossa here. So the structure we are interested in is the tuberculum. And then you see the chiasmatic sulcus, the planum sphenoidale, and the dorsum. So as we go along to look at the neurovascular structures, the important structures here are the second cranial, the optic nerves on either side, the pituitary gland and the infundibulum, and then the carotid on both sides. So the anatomy of the dura is very important because this is what gives rise to the vascularization of the meningioma. So these are the arteries that are commonly involved and supplying these tumors, essentially branches from the ethmoidal artery, and then there are others as the tumor goes posteriorly, if at all. Now, the interesting vascularity of this region that needs to be absolutely preserved while operating these tumors are these arteries, the superior hypophyseal artery and their branches, which supply the undersurface of the chiasma. So any amount of surgery and decompression of the nerve will not be good enough if these arteries are taken during the surgery. And this is this interesting paper that came a few years back that showed two groups of arteries, the pre-infundibular and the post-infundibular groups of superior hypophyseal arteries, which is seen in a large percentage of patients. So when we talk about tumors in this region and we look at literature, the problem really is one of nomenclature. Generally, we go by the site of origin, but the site of origin can be quite varied, and it's sometimes difficult to classify them. We can look at the midpoint of the site of the primary attachment and then label them as olfactory groove, as you see here, planum, tuberculum, and diaphragm. So sometimes they get intermingled, and that's the problem when we look at literature. It's a little homogeneous because of this variability, and that needs to be kept in mind. So some of these papers that talked about the attachment of the tumors and their anatomy. And interestingly, it's important to realize the anatomy of the arachnoid and the nerves, the neurovascular structures in this region. Why? Because that would predict how this tumor would grow. So the tumor generally grows anteriorly over the planum and over the optic nerves because there are barriers, these arachnoid barriers and the neurovascular structures that kind of limit to a certain degree the spread of the tumor. So when we look at literature and look at the presentation, there is a wide variation in the grouping in literature. So you have planum, which is clubbed with tuberculum, planum, and olfactory. Then you have tuberculum with diaphragm. So different types of tumors often taken together, but does it really matter? If you're looking at transcranial surgery, it doesn't really matter. The approach is almost the same. Essentially, what we want to do is to remove the tumor without damaging the cortex, the frontal lobe, and the important neurovascular structures in the region. So it's got a reasonably long history, these tumors. So Cushing was among the first to call them as suprasellar meningiomas, and this grading was based on the weight of the tumor in those years. And he remarked on how these tumors almost always present with visual problems. Yazergil put forth the classification based on the size for the first time because he had imaging at that point. And then Atul Goel from India, of course, he made a very detailed classification using a lot of parameters, including MR and the clinical symptoms. So sometimes it's a little difficult to apply this, but then basically these grading of these tumors are useful to evaluate the difficulty of the surgery. So Shaker and group came out with this classification, which is not too bad really. It takes into account the size, the optic canal invasion, vascular invasion, not really invasion when the tumor goes around the vessels, and then MR, he looked at brain invasion or essentially flare signal and whether there was previous surgery or radiation. So they gave a point system by which these tumors can be kind of graded based on their surgical difficulty. So this flare on both sides could point to a little more difficult surgery. When we look at these were the controversies that we wanted to address in our consensus statement. So the endocrine function, we look at some studies that studied the endocrine function. So this group came with no patients with neither pre or post-op endocrine, but that's not universal. You have other studies that show that there are rare instances of pre-op and post-op deficits. So generally, the results are inhomogeneous, but we think that routine endocrinological examinations are necessary, especially if they are of the diaphragma sellae origin. What to do for a transcranial approach, whether to do a unilateral or bilateral craniotomy. So the classical, the majority of people and the early publications were all on a unilateral approach, pterional or a variant of pterional. But then there were superior interhemispheric approach for tubercular sellae meningiomas, bilateral subfrontal. So a host of transcranial approaches have been described, but for the last possibly 20 years, more and more people are moving towards a unilateral lateral subfrontal approach because the outcome seems to be much better with a unilateral approach. But generally, the results are good with all transcranial approach. It depends on the surgeon preference, but possibly better results. And you find more and more studies in the last 2 decades that surgeons have talked about the unilateral approach. So generally, the unilateral approach is preferred. Now, when you decide on a unilateral approach, how do you do it? Do you do it through the normal hemisphere, the non-dominant hemisphere, or the dominant hemisphere? So the advantage of doing it in the dominant is you avoid complications related to dominant hemisphere surgery. But on the other hand, there are other important anatomical features that should be taken into consideration. Look at this patient with an olfactory, a very large olfactory groove meningioma that we approach from this side, the right side. As you can see some of the images here. Just run the video, it's not all that important, but basically a skull base approach, frontoorbital craniotomy, a very basal dural opening. Essentially, the necessity to go subfrontal without damaging this edematous frontal lobe on the right side. But what is important is to look on the image, the asymmetry of the T2 weighted or flare images. You can see it essentially only on one side. So that's a side in which there's only one layer and maybe two layers of arachnoid on the other side. And that's the reason why this lobe is not edematous. So it's always a good idea to go on the side of the larger edema. And there also look at the vessels that are moved. So all the midline vessels have been completely displaced to the other side. Another reason to come from the side of the larger edema in transcranial operations. Now this is an olfactory, so then you need to cut the fox as shown here to reach the tumor on the other side. So unilateral approach, you would go on the side of the larger origin and the side of the higher edema. But there are groups and for very good reasons choose to operate from the side of the better vision, possibly because there's less extension into the optic canal there. So this is a very popular method to operate from the contralateral side. Just to show you the advantages, we generally operate from the ipsilateral side, but this patient is a good indication of operating from the contralateral side. And why is that? Tuberculum sellae meningiomas, the attachment that's residual, this was a residual tumor, is always medial to the optic nerve. So from the contralateral side, the vision of the medial part of the optic canal and the optic nerve is excellent from the contralateral side. From the ipsilateral side, of course, this would be kind of a little bit of it would be a blind area. So for small tumors, especially residual ones, contralateral approach could have very good value. So the advantage is that you have a direct view of the inframedial aspect of the compromised optic nerve and canal, which is a blind area during the ipsilateral approach. But what is the problem? Problem is you have the ipsilateral normal optic nerve in your view all the time. So anytime instruments go in, you have to be careful that you don't damage the normal optic nerve. So otherwise, if that is not the case, many surgeons operate from the side of the worst vision because you do not want any complication with the normal optic nerve. So let's say you have a tumor here, a little more towards the left side, and you have some tumor going into the optic canal and patient presenting with the visual loss on the left side. So we would do it from the left side, a left frontolateral approach, and there's the result. After 3 years, you have no tumor residue and the nerve is well decompressed and it improves. So this is a very popular method for the unilateral surgery. And the idea is to preserve the non-compromised optic nerve and to decompress the compromised optic nerve. So what do you do when you have pneumosinus dilatans? And this is Bill Caldwell from the US, and he analyzed this large group of patients, and they looked at implications for surgery, both transcranial and endoscopic. The problem with the endoscopic approach, as always, and Luigi will be talking about it, is that you cannot forget that you need a very good skull base repair after surgery. So when you have a pneumosinus dilatans, you have this normal anatomy as seen here, type A, B, and C, depending on how large it is. And this is the type which becomes very difficult for the endonasal surgeon, but of course, that is just a question of experience. So generally, this type C is not chosen for endonasal, but all types are good for transcranial. But the majority of transcranial, transendonasal surgery, very often at least based on Billy Caldwell, is that they would propose it for endonasal surgery for the small tumors of type A. So this is an important consideration, especially if an endonasal approach is chosen. Now, the anatomy that we need to closely study for a transcranial approach and also for an endonasal approach is the orientation of the bone in this region. So you have a narrow, steep And these are the different types of the region, that is narrow and steep. Now the steep is this angle that we are talking about. So the narrow steep, wide steep, that means the optic nerves are widely placed apart, or a wide flat. So this angle is an important angle to consider. So this paper, please go back to this paper. They look at how the interoptic distance, the planum length, the sulcal length, and the sulcal angle is calculated, and the sulcal ridge. So all these are all important considerations when we plan operations for that. Now, this particular angle could be a little bit of a problem in transcranial surgery, where if the angle is very large, you can have parts of the tumor that's hidden origin. So in which case, this part of the bone needs to be removed for us to access that part of the attachment. So these are important considerations to be dealt with before the surgery. This is one of the questions that many people ask. Does the Sylvian fissure need to be opened always? The earlier experience 20, 30 years back was that surgeons would usually open the Sylvian fissure. But then in the last 2 decades, at least, after the advent of skull-based techniques, which are becoming more and more popular these days, the Sylvian fissure opening is not very much used these days. Maybe only the proximal Sylvian needs to be opened a bit. But then, of course, if you have a very large tumor, more and more of the Sylvian fissure needs to be opened. But for the standard tumor, very little of the Sylvian fissure needs to be opened. And that can be seen with new papers that have come out that show that modern skull-based techniques have taken off the need to work through the Sylvian fissure. So because the outcomes are obviously much better with these skull-based approaches. Now, once you decide on a skull-based approach, you have to start thinking about the opening of the optic canal. So the favorable visual outcome in this series, it's quite high when we open the optic canal. So there are groups that look at routine optic canal opening and have studied the use of this. The results are quite good with this opening. So I generally open the optic canal for all these cases. Now, if you do open, do you do it through an extradural clinoidectomy, or do you do it intradural and then open the falciform ligament? Now, this is a personal choice, really. I would generally go for an extradural clinoidectomy and opening of the optic canal extradurally. And that's been well supported from recent literature, showing that the preservation of vision and improvement is very high when the opening of the optic canal is done and from the extradural side. So what it does is that it gives a rapid relief of compression of the optic nerve, and then any kind of mobilization of the optic nerve, especially when we operate from the ipsilateral side, the optic canal opening is crucial, because the optic nerve may need to be mobilized to access the blind area on the inframedial side of the nerve. And it takes off the ischemia, and the results for sure are better when this is done. So I would say yes, optic canal opening is useful, and I would do it extradurally. Do you do it before or after tumor debulking? Well, the opinion is divided. There are people who answer in either way, but generally I prefer to do it before. And I would like the panel to talk about that at some point, maybe towards the end when decision making is addressed. Now we come to the important topic of extended endonasal approaches. Now there have been many studies from people with a lot of experience that show that when you take an appropriately selected population of tuberculum and planum sellae, planum sphenoidale meningiomas, the outcomes are better. But this is not a comparison. It's like comparing apples with oranges. And look at this study that looked at it in these two groups. The problem is that many of these studies, they compare endonasal directly with tuberculum, and generally the smaller tumors and the easier tumors are done endonasal, while the more difficult one with vascular encasement is done by open. And that's probably explains why the visual outcome is better. I'm sure Luigi will talk more about it. But I'll show you one case that we had to do recently in which we did endonasally. And why did we do that? This was again a recurrent case, meningiomas, multiple meningiomas, treated transcranially over the last 20 years before surgery, including one on the planum. And this time the tumor had recurred under the diaphragm, and we were very sure it was sub-diaphragmatic. And then we thought that the endonasal route would be the most ideal to address this. And this is the standard endonasal approach that we use for tumors in this region, but rarely we use it also for tuberculum sellae, only when it is infradiaphragmatic. So this is an excellent indication for an endonasal approach. Luigi for sure will talk more about this, so I would not persist with this. What are the limits of the extended endonasal approaches? The limits have been well analyzed in many studies, and this Fred Gentili's group who really brought out this article that addresses the issue. And essentially, it is for the tumor extensions that are lateral to the internal carotid and the optic nerve, and where the dissection becomes difficult due to vessel encasement. So these are the main uh, limitations. And then, of course, the usual problem of skull base repair. But with modern repair techniques, this has been more or less solved to a large degree, but then it essentially depends on the competence and the experience of the team, because once you have a CSF leak, then it becomes a big problem. So the idea is to avoid it right from the beginning. But one factor that we should not ever ignore is the long-term quality of life after endonasal surgery with respect to nasal function, because it is for sure, if we study it, we will see a significant decrease in nasal quality of life after endoscopic meningioma surgery. But this needs to be kept in mind and addressed when we discuss with our patients. Now, this is probably the only study which I found that was comparing two similar populations. So these are two institutes, including Professor Capabianca's group here, and Luigi, who's known for endonasal surgery, and the UCSF group, which is very well known for the transcranial group. And they tried to match two similar populations, more or less. And so we can get some important information from this study. They looked at the tumor score, the canal score, the artery score. So they looked at all the important factors that determine the difficulty of the tumor. And they found that at the end of the day, the transcranial approach had a higher tumor, artery, and total score. So essentially, these two groups, even though they are known in their respective fields, the more difficult tumors were approached through the transcranial route. So there's no doubt that the more difficult the tumor it is, the higher most people would go for a transcranial approach. But there's no difference in overall complication rates between these two approaches. But the transsphenoidal approach has more CSF leaks, but it is an earlier study, I guess, and maybe the CSF leak rate is even less now with modern repair techniques, but this is 2018, so it's not that old. The observed recurrence rate in between the two groups was 10%, and there was no difference between the two approaches. So essentially, this is quite a balanced study between two centers known for endonasal and transcranial surgery. So just to quickly show you some of our results, we looked at our consecutive series a few years back, 27 patients, and we used the Shaker classification. So most of them are class 1 and 2, and the large majority of them had presented with, as usual, with visual deficits. So this is the standard size of the tumor in our series. And just to show you quickly some, yeah, I have some time, some videos. So we generally do it from the side of,
Daniel, please.
pardon me?
Can you conclude in a few minutes, please?
Yes, absolutely. So just to show you a unilateral approach, and there's a clinoidectomy done here, so the optic nerve can be mobilized. The arachnoid should be preserved as much as possible, and the bipolar not used. And that's how the tumor can be done without really damaging any of the vascularity to the optic system. And so at the end of surgery, you can see the contralateral optic nerve, the contralateral carotid. And the vision is usually, it improves quite rapidly. I'll go through that. And then, of course, the diaphragm sellae, which is a much more difficult tumor to do. So this patient, in which we, as part of the procedure, we always do a standard frontotemporal craniotomy, and then we would do a clinoidectomy. That shows you this unroofing of the superior orbital fissure. That's the going towards the foramen rotundum there, you can see. And then the progressively, the base of the clinoid is removed. And then you can see as we go along that we see the falciform ligament and the optic canal completely opened. A very basal craniotomy is done. And you can see how the tumor is removed with preservation of the arachnoid and all the vessels. It's completely detached from the bottom there, from its attachment. You can see at the stalk at the end of surgery, the basilar artery, contralateral third nerve. So that's how we usually do it. If you look at our outcome, we had visual recovery in the vast majority of patients. Nobody had deterioration, no new CSF leaks, no mortality or major morbidity. One patient developed partial anterior hypopituitarism. We had anosmia in 2 and a fourth nerve palsy in 1. So I would like to conclude that the choice of approach essentially depends on the surgeon experience and the preference. A careful analysis of the visual status and MR features is mandatory. And generally with transcranial unilateral frontolateral skull base approach, the outcome for vision and tumor outcomes are excellent. Now this, all the points discussed in this presentation is summarized as part of the recommendations of the ENS Skull Base Committee, and I would urge you to read this paper that addresses these issues. Thank you very much.
Thank you so much, Daniel, for this very nice overview. It's now time to move to Naples to listen to Luigi Cavallo's talk about the transendoscopic approaches to those lesions. Please, Luigi.
Thank you so much, Michel. I'll try to share the screen. Okay. I will present in the next minutes the experience of our group in Naples, guided by Professor Capabianca on tuberculum sellae meningioma treated through the endonasal route. Tuberculum sellae meningioma is just one of the midline skull-based meningioma that can be treated through the nose. Through this route, we have removed more than 2,000 lesions, but majority is represented by pituitary adenoma, but also other midline skull-based tumor. And concerning skull-based meningioma, as you can see in this slide, the vast majority of the meningioma we have treated through the nose are represented by tuberculum sellae meningioma. This is the lesion we can approach through the nose, but to remove this kind of tumor, we have to be a little bit more invasive as we do to remove a pituitary tumor. In this case, in fact, we have to resect a middle turbinate. Just on one side is enough. We have to open the ethmoid cells on the same side. We have to remove also a little bit of the posterior part of the nasal septum. This because we have to create a corridor large enough to move properly two instruments through the nose. Of course, we need also some adjunctive tool, like, for example, the neuronavigator, which can be useful in some case. And we also need some dedicated instrument, for example, a micro drill with a long handpiece and low-profile instruments that can be used properly through the nose, like bipolar forceps, microdoppler probe, and ultrasonic aspirators. What we do when we have to remove a tuberculum meningioma through the nose? We have to create a sort of craniectomy just over the tuberculum and planum sphenoidale. And to do this, we have to resect this amount of bone. And this because at the end, this is the panoramic view we need to have. We have to control optic nerve from this portion below the falciform ligament. We have to see widely the supraclanoid portion of carotid artery, and we have also we need also a wide view over the planum, through the planum sphenoidale, because we have to dissect properly the tumor all around. For this reason, the opening we usually do, for example, to remove a craniopharyngioma is not enough. This is, for example, the opening we do for a craniopharyngioma, but when we have to deal with a tuberculum meningioma, we have to extend much more our bone resection. And if you look on this slide, you can understand why. If you look on the right, on the left side of the patient, you see the bone removal is extended laterally over the optocarotid recess, while on the right side, you see there was an incomplete bone resection. And this means that when you look the length of your opening over the through the tuberculum, you see that you miss this bone resection, and this means that your corridor will be restricted at this level. So it's very important, this concept, because you have no intradural corridor when you have to remove a tuberculum sellae meningioma. And it's very important that you remove properly the bone, otherwise you will do the same mistake when you try to remove a convexity meningioma through a small craniotomy. So this is the reason why you have to carefully remove the bone around the optocarotid recess. To do this, you have to understand very well the anatomy of this region, because as you know, we have two optocarotid recesses. One is the medial OCR, the other is the lateral OCR. And when we have to remove tuberculum sellae meningioma, we have to remove widely this bone from medial OCR to lateral OCR. And when we look transcranially, what does it mean? It means that we have to remove the bone here in this area. And as you can see, when you remove the bone endonasally in this part, you will not risk to damage the optic nerve, simply because the nerve is not yet inside the canalicular part. So this is crucial for this approach. And if you remove properly the bone on this area, you have solved most of the problem for the tumor resection. This is nicely explained in this paper made by Alberto Di Somma and with our group and Barcelona group, which clearly show the amount of bone you can resect. This is an extended approach of the planum, but theoretically you can remove all this bone, including the anterior clanoidal process. This can be done if you resect the less sphenoid wing through the nose. You see, you can decompress the optic nerve widely. You can do a reverse clinoidectomy, as you can see here. In this way, you can expose widely the optic nerve until the entrance in the canalicular part. You can even work above the optic nerve like a true transbasal approach and expose even the bifurcation of a carotid artery, just to give you an overview of the possibility. Of course, the removal of the tumor has to follow the same principle of a transcranial surgery. This is has been nicely described by Al-Mefti with the DDDD technique. And this is a video just to show what happened. We early devascularize the tumor, and then we debark with the diffuser. And if you open widely laterally, the dissection is quite easy. You see, you can have a nice view on the optic nerve. You can nicely dress the tumor from the A1, A2 complex, and then gradually you dissect the tumor from the chiasma and the stalk, and at the end you can remove completely. But look what kind of view you need to have laterally. You need to see the supraclanoidal portion of the carotid, the ophthalmic artery, and you need to see these on both sides. If you create this wide corridor laterally, the removal of this tumor is really, really much easier, but of course with proper surgical indication, as we will see. Factors affecting the outcome in TSM, of course, are the same of what we have when we manage this tumor transcranially. The first thing we have to consider, of course, is the dimension of the tumor. And as Daniel Ray said before, the vast majority of the tumor we treat are small or medium size. But this does not mean necessarily that small tumors are easy. Because they, even when they are small, they can have a wide extension in the optic canal or have a vessel encasement and so on. But we can manage this tumor, small to medium size, with good postoperative removal, but we can even imagine some selected large tumor, like in this case. For example, this tumor was operated before transcranially. We didn't complete resection, and you see here some brain damage made by the previous approach. And then we have managed this tumor endonasally with the gross total tumor resection. So even quite large tumor can be removed with through this route. Or this is another case, also quite large tumor, but of course not in all cases you can achieve tumor complete tumor resection. We left here, you can see some remnant. But of course, one of the main benefits of this approach are in regard to the visual outcome. And this is the reason, because when you manage this tumor through the nose, you almost do not touch the optic nerve. And this is very important, especially when you have a severe neurovascular conflict with the A1, because practically you remove the tumor without touching the optic nerve. The results are quite good, especially when you look the visual outcome, and especially when you look the outcome in those patients with a severe preoperative visual field defect. And this is, of course, important, especially when you want to preserve also a residual light perception, for example, to have still a binocular vision. So this is something you have to consider. And since the beginning in the literature, there are a lot of papers considering this kind of approach, even with large series. For example, this is what comes from the Pittsburgh group, with a very good visual outcome. But another thing we have to consider is not just the compression of the optic nerve, but even the extension of the tumor inside the canalicular part of the optic canal. And you see here one case, not big, but this case I want to show you just to illustrate how this tumor can be very, very invasive inside the optic canal. What we made in this case, we decompress the optic canal until the orbit. This is the papyracea. And you see how invasive can be some of these tumors when they purely extend inside the canalicular part of the optic canal. And you realize that practically you cannot cure this patient. Whatever is the approach you use, endonasally or transcranially, you see that the tumor is widely extending inside the optic canal. You see here the ophthalmic artery, but despite you try to open all along the optic canal, you still find tumor which surrounded the nerve. And for sure, the cure for this tumor will never be only the surgery, and we have to look hopefully for some drugs which will help to treat better this patient. Another problem to consider is the vessel dissection. Of course, we have some limitation when we do endonasally, but you can have, like often happen with tuberculum sellae meningioma, a good arachnoid plane, and you can quite easily dissect this tumor from the nerves. But of course, this is not the situation you will have always. Of course, you have a more difficult case like this one, in which you have partial encasement of anterior cerebral artery, but you still can have the possibility to dissect this vessel. But there are cases in which you can have encasement of some perforating vessel, and I think that in this case, even transcranially, maybe it's not safer to try to dissect this teeny perforating vessel. Another crucial point to consider when you want to approach this tumor from below, of course, is the configuration of the sphenoid sinus. And this is also another nice paper made by Matteo De Notaris and Domenico Solari some years ago, which nicely show the good and the bad configuration of the sphenoid sinus, and at the level also of the tuberculum sellae. This means that you can have a good angle of the tuberculum sellae, wide angle on the tuberculum sellae, which render quite easier the approach to tuberculum sellae meningioma. While on the other side, there are bad configuration of the sphenoid sinus, in which the procedure will be more difficult. With a good angle, with a wide angle on the tuberculum sellae, you see you can easily have a nice view above and below the chiasm. This means that you can more easily dissect vessel with this corridor above, and also below the chiasm, you can nicely dissect the tumor from the stalk. This is a good example of wide angle, or I prefer to say deep sella. You see, this is quite a deep sella, and you have a nice corridor with a good tumor removal. This is even better. You can look here how deep is the cell in the skull base. You can have a tumor which reach the level of the pituitary gland, and in this situation, to remove the tumor from below seems to be a good option. But on the contrary, you can have a configuration of the sphenoid sinus like this one. This is a short cella. This is a narrow tuberculum angle with a broad base of attachment of the tumor over the planum sphenoidale. And this is probably not a good indication for a nasal root. This is quite an old case, and you see we miss some remnant in this case. And for the same reason, for cases like this one, with the broad base of attachment of the tumor over the planum, we think that there's no need to force the indication of the endonasal root for cases like this one, which can be more easily treated through the transcranial route. But of course, still there is an indication for cases like this one with a small attachment over the planum, for cases like this for the endonasal root. So there are, as we said, some criteria of selection. Not all the tuberculum sellae meningioma can be managed through the endonasal route. And for us, the best cases for endonasal route are those small or medium size, with no complete vessel encasement, no broad dural attachment or extension over the planum sphenoidale, and especially those cases with deep sella are probably the best case to be treated to the endonasal route. This is a paper Daniel Roy already showed you. I will not enter into the detail. Also, this one more recently made by Ted Schwartz also underlines some risk factor for endonasal surgery, which are prior surgery, tumor lateral to the optic nerve, or complete ICA encasement. But I want to show you, this survey was made 5 years ago by WNS on tuberculum sellae meningioma, and you can see that already in 2050, the endonasal route was considered for tuberculum sellae meningioma at the same level of pterional surgery. So especially in US, this technique is quite widespread. And even if we look around the globe, especially in Korea, in China, or even in smaller countries, you see that most of the group are doing comparison with transcranial surgery or purely doing endonasal surgery for tuberculum sellae meningioma. And you see the most of the case, they put the finger on the visual outcome, because maybe that is the main benefit of this approach. We also made some contribution as a ENS skull-based group. I would like to conclude with the skull-based reconstruction, because this really represented the limitation of this approach, especially in the past. We had a lot of CSF leak, so it's reasonable to have a criticism on this technique. But we completely, we improved a lot with this technique of 3F, which is quite easy to perform and also very fast. We do not have to waste a lot of time at the end of a surgery when we are tired. This technique requires just 5 minutes to complete the skull-based reconstruction. What we do is simply to use a FET, and FET is not new in transsphenoidal surgery. The surgeon Collin in the 70s already proposed the use of FET, and other pioneers like Ed Rose, Kelly, Charlie Teo used the FET either in transsphenoidal for pituitary or for extended approach. But it's very important how we use the FET, because what we are proposing now is to use the FET as a cork stopper. We just use 1 or 2 large pieces of FET that are moved across the skull-based defect. We do not use just to fill the cavity, and we have completely abandoned all this technique we also used in the past. We cover the FET, of course, with the flap, which is a pedicle nasoseptal flap, but we are also starting to considering free flap. So we are also considering the possibility to avoid nasoseptal flap. So fat and flap, and then we flash mobilize the patient from the bed. We never leave the patient supine in the bed. And I would like to conclude with this case. This is a tuberculum sellae meningioma, also with an incomplete pleomortization of the spine and the sinus. But this is what we do at the end. To reconstruct, we plug through the skull-based defect this large piece of fat, no risk of overpacking, because you see the transmitted pulsation of the brain through the skull-based defect. So you will not fix the fat only inside. We just put some fibrin glue over the fat, and then we cover with the nasoseptal flap the defect. And that's all. It's quite easy procedure. You see in the post-op CT scan the concept of cork stopper. Part of the fat is inside, part is outside. But most important, you see the fat which seal all the corner of the skull-based defect. This is the post-op MRI. You see how it appears with the suppression fat sequences. And also another important thing, that the fat will be resorbed over the time. So no risk to have some fat tumor or something like that, no, because the fat over the time, and this is something we are checking now in all the control we made, in some of the cases it completely disappears. So this is also something to consider. I think I've finished my presentation.
Thank you so much, Luigi, for sharing with us your tips and tricks to manage so wonderfully tuberculum sellae meningioma through an endoscopic approach. I will now discuss the transcranial approach to tuberculum sellae meningioma. So I share my screen. Can you see my screen?
Not yet.
Not yet. It will arrive very soon.
It's okay.
It's okay. Perfect. And now in full mode. So I will discuss with you the transcranial approaches to tuberculum sellae meningiomas. As Daniel already discussed previously, tuberculum sellae meningioma arise, in fact, in this area of the sulcus chiasmatic. Those lesions are most of the time smaller than the ones expected at the level of the olfactory growth or planum sphenoidale. And those lesions, despite smaller and maybe discovered, why smaller? Because they are compressing more severely the optic nerves, and they've, as explained in detail by Luigi Cavallo, a canal extension, which is truly problematic to manage. Of course, in this location, the lesions are also in direct relations with the vessels of the polygon of Willis. We are dealing with such lesions. We have to compare on one hand the efficiency of the approach and on the other hand the complication rate of the different possibilities. The efficiency means the resection rate, the neurological outcome in terms of olfaction, vision, in terms of neurocognitive function if the brain is injured by the approach when you perform a transcranial approach, also the cosmetic outcome, and on the other hand the complication rate, meaning the morbidity due to CSF leakage or vascular damage. The recurrence rate of the tumor has to be taken into account, as well as the mortality, of course. Basically, there are transcranial and transsphenoidal approach, and in the group of transcranial approach, there are several approaches that can be selected. When we look to the literature, there are two meta-analyses which have compared both endoscopic and transcranial approach, and it is interesting to go into the detail regarding the tuberculum sellae meningioma. In terms of gross total resection rate, when they analyze and compare the microscopic transcranial approach with the endoscopic transsphenoidal ones, they observed that the gross total resection rate was not significantly different between both approaches taken into consideration. On the other hand, when you perform a endoscopic transsphenoidal approach, the risk of olfactory loss was higher compared to a transcranial approach. The main problem is regarding the vision. When you compare both groups, the improvement after a transsphenoidal approach was significantly higher than after a transcranial approach. Not surprisingly, the rate of CSF leaks in this meta-analysis, of course, some teams have better results. The rate of CSF leaks was higher among patients treated transphenidally, and it was significantly different. Performing a procedure transphenidally is also associated with the significant higher risk of intraoperative arterial injury, and the risk of mortality was also higher compared to a transcranial approach, but this difference did not reach a significant difference. So the main concern regarding the disadvantage of the transcranial approach, for all the other aspects, the transcranial approach was better than the transsphenoidal one. But for the vision, in terms of vision improvement, it was not the case. And it is interesting now to focus maybe a little more on this point. When you look to the different approach, transcranial approach to tuberculum sellae meningioma, you have approach from the midline, the anterior hemispheric approach, and then you can move to more lateral approaches, subfrontal approach, bilateral, unilateral, transbasal, and move to lateral approach, frontolateral or pterioidal one. On this view, this table, you can see regarding the different aspects, the advantage and disadvantage. It is a little bit more too extensive, but I will discuss with you the different approach now. When we perform a subfrontal approach, which is a quite old approach used for this kind of resection. You have an axis which is in fact tangential to the anterior cranial base. You see the axis extremely tangential. It means first that you have to open the frontal sinus. The olfactory nerves are at risk of injury. There is a need for frontal lobe retraction, especially if you would like to reach the area behind the tuberculum sellae. This is the main limitation. And you have also a limited access to the optic canals. You see an overview, limited access beyond the tuberculum sellae, limited access in the optic canals. In fact, only one study has compared the different transcranial approach to tuberculum sellae meningioma, and it was done by the team of Majid Sami. At that time, 72 patients were operated on either by a bifrontal approach, a frontolateral approach, or a pterional approach, and the number of patients was quite similar in the groups. What are the conclusions, in fact? The visual improvement was significantly lower using a bifrontal approach compared to the other. Complication rate was significantly higher, as well as the mortality. And for this reason, the subfrontal approach, bifrontal approach, is less recommended, and the more lateral approach were more favored. This was clearly demonstrated in this paper comparing the transcranial approaches. What view will you have through more lateral approach, meaning the frontolateral, supraorbital approach, or the pterional approach? To a frontolateral approach, you will have a tangential view over the homolateral optic nerve and a more perpendicular view on the contralateral optic nerve. With a pterional approach, you turn a little more the head, you will have the homolateral optic nerve, which is even more in phase of you, and you have to manage the tumor pacing above and below the optic nerve, which places the nerve at risk, and it has been detailed in the talk of Daniel Rowe. Well, which size have you to approach this tuberculum sellae when you have hidden area behind the homolateral optic nerve, and so even more hidden areas when you approach to a pterional approach? Some surgeons will favor to approach from the broad side. It means that the rationale is to preserve the non-compromised optic nerve, but on the other hand, you have more manipulation of the compromised optic nerves. Some surgeons will approach from the best side, the best optic nerve function, but it means with the benefit of minor manipulation of the compromised optic nerve. But the hidden areas are higher beyond the tumor, beyond the optic nerve. So if you approach by a frontolateral or a pterional approach, of course, it's a skull-based approach, and you need to retract the brain as less as possible with drilling the bone. This is clearly evident. You have to try an early devascularization and an early optic nerve decompression. When you look to the main article published in the literature, but we already discussed this article before during the Daniel Rowe's talk, you have for the supraorbital approach one main article published by the Helsinki team by Juha Erniestemi, covering 52 patients. You see that the gross total resection rate was 87%. In terms of vision improvement, 1/2 of the patient improved, 1/3 remained stable, and 15% deteriorated, with quite correct side effect after the surgery with the low rate of CSF fistula. As in an important paper published by Falbush about the pterional approach, on 47 patients detail a gross total resection rate very high, 98%, and in terms of vision, the results were also extremely good. When the vision was preoperatively normal, then it remained normal, stable after the surgery. When the patient has a preoperative deficit, 80% improve and 20% deteriorated. The visual outcome was in relation clearly with the duration of the symptoms before the surgery and with the age of the patient. I will now describe one of my favorite approach, which is the anterior interhemispheric approach, and why it is my favorite approach. For olfactory growth meningioma, no doubt. The axis is straightforward and the lesion is 1 centimeter below the axis. No frontal sinus injury. It is not a subfrontal approach. It is an anterior hemispheric approach sparing the frontal sinus. You can early devascularize the lesion. You have access to both optic nerve. When treating more posteriorly lesions such as planum sphenoidale meningioma, it remains my favorite approach. The brain retraction is limited, but you have to think how to retract the brain as less as possible. If you perform an approach homolateral to the more extended tumor part, then the brain retraction is higher compared to a contralateral approach. You see here the area that has to be retracted is extremely limited. And you see through this anterior hemispheric approach how you can remove this lesion without creating any brain injury. This is the approach to 15 millimeter. You see the and you see how you see the optic nerve, the chiasm on one side and also on the other side. It is why the anterior interhemispheric approach is my favorite approach. You have not to choose which nerve optic you have to reach first. You have access to both optic nerves, the more compressed and the less compressed as well. You have full control on the vessel. This is a view of the approach. And you have also one point that is truly important is the control behind the tuberculum sellae, where the tumor comes from. This is the view you will get on the optic apparatus. Both optic nerves will be visible as well as the optic chiasm. All vessels can be controlled. You have access behind the tuberculum sellae. You have access on both optic canals. It is truly important. This is a video showing how it is during this procedure where in fact all the vessels were embedded in by the tumor. This is the left optic nerve. This is the left carotid. You see how the tumor extends on both sides of the anterior cerebral artery. You have one part of the tumor in front and one part behind, but as you can control the vessel distally, you can follow the vessel from distally to proximally. You can have a proximal control. Having a control proximal and distal allows to work more safely. This is a left-sided approach. This is now how the tumor is deburred. You will see the sparing of all perforating vessels. This is the right optic nerve, which is now into view. This is the decompression of the anterior cerebral artery. Gently mobilize. The main problem is in this tumor, you see the right optic nerve is the extension between the carotid and the optic nerve. You will see now that the tumor will be progressively dissected. You see the third optic nerve appearing right here. And the tumor will be progressively attracted below the optic nerves. The optic nerve is in fact immobilized with the forceps, and all vessels vascularizing the nerves are spared. You will see all those small vessels which are perfectly spared by this technique. This is the carotid artery. This is the microvascularization of the optic nerve, perfectly spared. And now what is extremely problematic when managing those patients is the extension into the canal. And when you come from a lateral approach, the optic nerves prevent you to reach this area. You see perfectly well the right optic nerves. You can perfectly well see it, but it was not necessary in this case, the intracannular component of a tumor. You have then access to both optic canals. You can see now this extension is gently removed. You see the ophthalmic artery coming into view, and now you can be sure that there is a full decompression of the optic nerve. And because the tumor has been debugged early in the surgery, there is no lateral pushing of the optic nerves or against the falciform ligament. And with this approach, no need to open the falciform ligament. This is the view at the end of the surgery. One important point, a blade is placed. This blade is not placed on the brain. This surgery is performed retractorless. The retractor is in fact placed on the forks. This is the postoperative outcome without any injury to the brain and improvement of the vision. That is not surprising since both optic nerves have been completely decompressed. If you look more specifically to the literature about the anterior interhemispheric approach, you can see that in comparison to the meta-analyzing, where the results were more favorable for the transsphenoidal approach, when you specifically look to the transcranial approach performed to an anterior interhemispheric approach, the results were better. Two studies, one smaller study with 9 patients, another with 20 patients, demonstrated high rate of vision improvement after an anterior interhemispheric approach, and it is not surprising for me for the reason I just detailed. So when performing a surgery for a tuberculum sellae meningioma, the goals must be a complete tumor resection without any brain lesions. You should also have as goal the vision improvement. This is one of the main goals of the surgery, and of course preservation of the olfaction. The transcranial approach, in my opinion, still remains the preferred choice in most neurosurgical centers, can be indicated for any tumor size, irrespective in fact of tumor morphology or vascular encasement. When we look to the different approach, the frontolateral or pterygium approach are associated with a high rate of gross total resection, a good outcome with a low morbidity. In my opinion, the anterior interhemispheric approach is a valid alternative, and the subfrontal approach is maybe a little more questionable. The endoscopic endonasal approach remains restricted to selected cases, with limitation with respect to tumor morphology, and has advantages to visual function in selected cases. Thank you. So I finished my talk. I will stop to share my screen, and I will invite Sébastien Fenisch to come to the floor and discuss now. He has in his hands both techniques, transsphenoidal, transcranial, and maybe made some clarification. Up to you, Sébastien.
Thank you very much, Michael. I'm glad to see you all. So let me share my screen. A lot have been said already. I have in my presentation, I have nothing very new to say because most of it has been said. And Henry is following me also, so he will say even more. So subject of my talk was to discuss about endoscopic versus open. In fact, it's a quite easy discussion for me because I have almost completely stopped to do endoscopic endonasal approach for tuberculum sellae meningioma. But still, I think there is some indication that remains, but even more, I will explain why I have stopped doing those endoscopic endonasally. So we have seen some very nice pictures from the previous speakers, Daniel, Luigi, about the anatomy. I'm not going to say more. This is endoscopic view of the posterior wall of the sphenoid sinus. And you can imagine that this is extremely variable because of the pneumatization of the sphenoid sinus that is also very variable. What does not much vary is looking at the periostome behind the bone once you have drilled all the bone. Daniel has also shown some studies that we have made quite a long time ago already with the team of Cincinnati looking at the anatomy of the tuberculum sellae region. It's extremely variable. As you can see here, you have tuberculum sellae which are very steep, some very flat, and this obviously change the perspective you have, the look you have on this region, either endoscopic or transcranial. But it's important to be aware of those variations. You have same variations about diaphragma sellae. I would say even more. There is not two patients with same anatomy of the diaphragma sellae, because the variations of the dural layers add to the variations of the bone. So there is a lot of variation, and it also changed the shape of the meningioma, because some are going very easily into the sella because there is no diaphragma sellae. Some are going very hardly into it because you have a very narrow opening through the pituitary stalk join the pituitary gland. Classification is very important because we have to compare, talk about the same thing if we want to compare our results and draw some conclusion. Planum jugum is different from tuberculum, in my opinion. Tuberculum is definitely different from diaphragma sellae meningioma, more posterior, which are much more challenging. Daniel has perfectly emphasized this aspect. Preoperative workup helps to look at the features of the meningioma, the difficulties, the variations that could be encountered during the surgery. Fiesta and cyst sequence are extremely important because you can really see the chiasma, the optic nerve related to the meningioma, as well as microvessels. It's important to look also at the optic canal to see if there is tumor inside, because you may remove the tuberculum sellae meningioma. Symptoms will not improve just because you left tumor into the optic canal. And sometimes, it's not very often, but sometimes it's really the optic nerve sheath that is infiltrated by the tumor. And this is extremely tough to treat. And surgery may not change anything. I have seen sometimes meningiomas that I thought would be into the sella, will be into the sella, but in fact, it was a contrast enhancement of the pituitary gland and the meningioma at the top of it. And if you look at some other sequences, you can see the clear differentiation at the level of the diaphragma sellae. So you have to be careful with this. Sometimes you have the feeling that the meningioma is going very low behind the tuberculum sellae, but it's not always the case. Sometimes it's just contrast enhancement of the gland, which may be difficult to differentiate. So this is an example of cyst sequence where you can see the chiasma here, very thin behind the tumor. If you browse all the sections of this MRI, you can really follow the optic nerve, know exactly where it is according to the tumor. Extremely important piece of information. So extended endonasal approach, it has been a revolution in skull-base surgery. As you know, a lot of indication came with this new technique. There is multiple advantages of extended endoscopic endonasal approach. First, it's a logical line of sight, no brain retraction. You have access to the tumor behind the tuberculum sellae when the tuberculum sellae is steep, and it's an advantage. You remove the bone on the dura, you devascularize first. You have quite limited manipulation of the optic nerve and chiasma because you're tracting down the tumor away from the nerve. And in my opinion, it's a main advantage. And this is why endoscopic endonasal approach may have better results for vision, definitely. You may see better those tiny vessels, superior hypophyseal, going to the chiasma. And you can decompress also the optic canal coming from down, drilling the medial aspect of the optic canal that you can easily identify if you look at the posterior wall of the sphenoid sinus. There is limitation when it goes laterally to the ICA, to the optic nerve, when there is vessel inside, and there is also the risk of CSF leaks. That is the main factor why people are not really jumping into the endoscopic endonasal approach for meningioma, because they are afraid of CSF leak. So those are not solved, and I think Luigi also talked about those limitations. When it's going lateral to the carotid artery, it's definitely not a good case. So there is meta-analysis that have looked at results between endoscopic approach compared to transcranial. It's very tough to draw some definitive conclusion with those meta-analysis because it depends of the number you are doing, the experience you have with endoscopy, the experience you have with keyhole. But anyway, it makes sense that the risk of CSF leak is higher with endoscopic endonasal. It's close to 0 if you have not opened the frontal sinus with an open approach. This is obvious, it's common sense. And for vision also, it makes sense that with endoscopic endonasal, you may have better results in those cases with a very significant compression of optic chiasma and optic nerve, because again, sometimes the nerve is very thin, almost transparent, but if you track the tumor away from it, it's better than manipulating the nerve with an open approach. So there is this publication that has compared the results with endoscopic versus transcranial from 2 institutions, Luigi and Professor Capabianca institution and UCSF. It's a nice paper, and it shows about the same, that there is more CSF leak with transcranial, with endoscopic endonasal. The only thing that I don't completely agree with this manuscript is that the approach used for transcranial is mostly a quite wide, large approach bifrontal for most of the cases. And it's not completely fair to compare those techniques. If we compare keyhole approach in a very experienced surgeon to endoscopic endonasal, then it's more fair. And I'm sure if we compare the series of Henry, which is who is a master with keyhole approach, we will have much better results than the one reported with large, wide, bifrontal open approach in terms of comfort for the patient. What is the risk? What raised the risk of leakage, in my opinion, with endoscopic endonasal? Large defects. The wider is the tumor base, the wider you need to open, and the higher is the risk of CSF leak. When it's going quite far laterally, you have to look for this tumor laterally and open wider laterally, you increase the risk. I think that whenever you drill the optic canal, open the optic nerve sheath laterally, it makes sense that you increase the risk of CSF leak because it's more challenging to close. There is no clear data on this, but it makes sense, it's common sense. When you have a high BMI patient, obese patient, the risk also increase. And when you have during the surgery intraoperative bleeding and you have some kind of meningitis postoperatively, aseptic meningitis, probably you increase also the risk of CSF leak compared to a completely clear surgical field. So I have done this endoscopic endonasal approach for quite a long time, but I stopped again a few years ago, maybe 5-6 years ago was my last case, because I was a little bit disappointed with this risk of CSF leak compared to the keyhole approach, which was 0 risk of CSF leak, and also because of the postoperative discomfort of the patient that I thought was higher with endoscopic endonasal approach compared to the eyebrow keyhole opening. Here is a case, I think it was one of my last case. I had this little perforator coming out from the ACOM complex. I had a very hard time to dissect these vessels, but in fact, I made it. But what I thought is that if you have an avulsion of these vessels during the surgery, it may not bleed because you have vasospasm and it's immediately solved, even if you don't coagulate. But maybe it is the explanation for some bad postoperative hematomas that you can also have with endoscopic endonasal technique. So in my opinion, in fact, the good cases for endoscopic endonasal approach, the ones that I really would like to do with endoscopic endonasal approach because the line of sight makes sense, are the ones that are the most difficult to do with the higher risk of complication. It is the one with significant optic nerve and chiasmatic compression, and usually they are more posterior. But the ones that are more posterior are also the ones that have closer vascular relationship, tight relationship with the vessel. And it's also the large lesions, but the larger it is, the most difficult and risky it is also with endoscopic endonasal approach. So the question is to solve the risk of CSF leak and to bring it very close to zero. But this is also related to experience. You cannot start endoscopic endonasal technique with for tuberculum sellae meningioma and right away being the best with a very, very low risk of CSF leak. It takes time to develop a technique, but meanwhile, those patients, I think, are exposed to a risk that is too high compared to classic keyhole or classic open approach. Few words about open approach. There has been definitely a trend towards minimally invasive technique. This is a keyhole concept. I'm sure Henry will talk about it more. This is what I use personally for those meningioma, a small eyebrow incision. It's a very comfortable opening and outcome for the patient. You don't need retraction. You can put the endoscope at the end to look behind the tuberculum sellae or to look in the medial aspect of the optic canal if there is infiltration with angle scope. So the deeper is the lesion, the easiest it is. And we are here in the perfect situation with tuberculum sellae meningioma. It's an approach with whom you have to take advantage of the bone as much as possible. The inner table must be drilled as much as possible to increase the angle of exposure. So there is different types of keyhole approach. The one I use most of the time is supraorbital. I used in the past a little bit more minipterional, but now I have to say that the vast majority of cases I do it with supraorbital because the outcome is better and they don't have pain, mastication pain. So there is very good series now in the literature about trans-eyebrow keyhole approach. Some of those papers come from Henry. The indication, I think, is perfect. When it's more anterior, it's remained a good indication, but also the minipterional, as I told you, I'm not doing it anymore because of mastication pain, because you need to make an incision into the temporalis muscle. But the more anterior it is, the more difficult the anterior aspect of the meningioma is difficult to reach with the supraorbital keyhole approach. So for those cases, for example, it is, I think, easier to reach with the lateral supraorbital approach. And this is what I use, for example, for olfactory groove meningioma. Cosmetic is very important to consider when you decide between a keyhole eyebrow incision and a classic incision behind the hairline. In a guy like this, I think it's interesting to do a keyhole. In an eyebrow incision, in a guy like this, doing an eyebrow incision doesn't make much sense. If you have any kind of difficulties that you are expecting, the hairline is very anterior, so why not just doing a frontotemporal incision very anterior? It's the same. In a woman like this without eyebrow, doesn't make sense to do an eyebrow incision. So this is typically a case where I take advantage of the small keyhole opening, but I use a classic frontotemporal incision because the hairline is good for it. So for keyhole, you need good brain relaxation. I am not using retractor, and most important is to release CSF first. I think you don't need retractor because the brain is more attached to the convexity because of the arachnoid trabeculae. So the brain is not falling on the anterior fossa like it can happen when you do a wide opening. This is probably the reason why, in fact, when you drain CSF, it's absolutely perfect. You have plenty of space and there is absolutely no need for retraction. What can I say about the incision? My tip and tricks, I use the microscope from the beginning inside the eyebrow. I go directly to the bone and I use running stitch. I remove it at G6. Be careful with coagulation because the more you coagulate the skin, the more it can be cosmetically not so good because you burn the follicle. Be careful also with the microscope lights. At the end, it can burn the skin, and be careful with retraction also. Bone flap, supraorbital or orbitopterional, orbitofrontal, it depends of what you need in terms of exposure. But adding a McCarthy keyhole with the removal of the anterior rim of the orbit, superior rim, in fact, is not so much of a big deal. Take advantage of the inner table. And most important is that you need to flatten absolutely the superior wall of the orbit. You know that when you do an extradural approach of the superior wall of the orbit, there is bump on the superior wall. All this should be flattened very close to the periorbita, because this is really the space you need to be able to work in such a narrow space. CSF drainage, you have to go first to the carotid cistern before going towards the meningioma. If the tumor is big, you can go a little bit more distal into the Sylvian fissure. Quite often, you can find some arachnoid to open and to drain CSF. Once the CSF is drained, it's the exposure is here. There is not need to do more for the vast majority of cases, because the brain is falling away from the tumor. Do I open the Sylvian fissure? Not so often, only for big tumors. It can help to open the Sylvian fissure proximally deep to facilitate optic nerve chiasma exposure. Falciform ligament opening, I think it's nice when you have very impaired vision preoperatively, because you feel on the MRI that there is a significant compression of the optic nerve. Just making an incision on the falciform ligament may help significantly and give you more room to manipulate the optic nerve. This is a case here. You can see the exposure of the optic nerve, and after exposure, opening of the falciform ligament. And in fact, this was really the point of compression. And you can see the print of the falciform ligament and this optic nerve. And this print is definitely what was causing impaired vision in a case like this. So it's very useful, not only for tuberculum sellae meningioma, but for any kind of compression of the optic nerve from down up, just before the falciform ligament or below the falciform ligament. Optic canal opening, very rarely, only the medial aspect of the optic canal, because this is where the meningioma is going in the vast majority of cases. You don't need to open the optic canal laterally. You will not find meningioma in the vast majority of cases, except if you feel that it will happen because of the preoperative MRI. I show you a few cases. This is, as you can see, a case that could have been treated with endoscopic endonasal, considering that the tuberculum sellae is steep and the tumor is going quite far down. But in fact, I used the keyhole approach, and then I put the endoscope inside. So this is the approach, optic nerve, debulking of the tumor. As you can see, there is no retractor, no need for retraction. I take everything I can with the microscope. I open here the falciform ligament. I did not drill the optic canal here. I thought it was not necessary. And I remove this tumor from the medial aspect of the nerve. But here I have to look inside. And before closing, I put the endoscope inside, because I'm not completely sure that I removed everything. It's a 45-degree scope, I believe. And I can see that there is still tumor below the nerve. And this is really what you need to take out. Because again, if you leave this behind, you can have the same visual symptom post-op, because this was the place of the significant compression. I put this section to try to take as much as possible of the meningioma here from the medial aspect of the nerve. Okay. I skip this one because I'm a bit late. This was another case here, even steeper tuberculum sellae meningioma. You can see it's almost a vertical plan above the sella. So definitely here, I agree that it could be a good indication for endoscopic, because I'm not doing so often with the endoscope, I did not felt comfortable doing it with the endoscope, and I use a classic transcranial approach. Keyhole, the same. I have to say I was a little bit limited behind this very steep tuberculum sellae meningioma, tuberculum sellae, but still I could, with the endoscope, visualize this part of the meningioma. This is a CIS sequence that allow you really to follow the nerves, the vessels, and to have a clear idea of the relationship between those. Patient was almost blind on the left. This is a post-operative MRI. This is a control of vision. He improved very rapidly his vision. This is the keyhole. You see that I use those little hooks. I'm very careful with the retraction of the skin. I did here an orbitofrontal craniotomy, taking the rim of the orbit out. You flatten here as much as possible the roof of the orbit. And once it's very flattened, once you have taken advantage as much as possible of the inner table, you open the dura, evacuate CSF, as you can see here, and then I work on the meningioma. Progressive debulking of the tumor, take some tumor below the optic nerve. It's usually easier on the opposite side. I go faster on the MRI. I work on the tumor base first, and progressively I take this tumor out away from the optic nerve. Okay. But at some point I was limited behind the tuberculum sellae, could not see, and I felt that there was a significant amount of tumor behind. So that's the point where I put the endoscope inside, and yes, there is this piece of tumor here behind the tuberculum sellae that I progressively remove with ronger, with coagulation, with suction. And it was not a complete resection in this case, because I think I left a little bit of tumor in some corners, but very, very little amount of tumor. I was able also to visualize the medial aspect of the contralateral optic nerve, where there was some tumor inside. It was the worst optic nerve. I decided to come from the right here because the eye was worse on the left. So I want to come from the opposite side to have a better access to the medial aspect of the nerve. This is why I went from the right side. I always choose the opposite side of the worst optic nerve. And here was a resection of the tumor inside the optic canal. Cannot guarantee that I did not left a little tiny piece, but at the end I see here the ophthalmic artery, which is a good sign that you have quite well decompressed this medial aspect of the optic nerve. This is a skin incision. You don't see much because it's inside the eyebrow, because you remove the stitch at G6. I think it's key. One final case here of tuberculum sellae meningioma unilateral side on the left side with a significant amount of tumor going into the optic canal. So this could be a nice, nice case for endoscopic endonasal. But I think that if you open this optic canal widely, the optic nerve sheath, it's not so easy to close. And I would not say that the risk of CSF leak is very low in a case like this if you come from the nose. So I decided to use a contralateral approach. And here is the case. With a keyhole, you're very rapidly at the point. Here, drilling a little bit of the medial aspect of the optic canal. You have to be careful not to get into the sphenoid sinus. So this has to be carefully checked on the preoperative CT scan. And here I was fortunate enough to be able to really take this piece of meningioma in almost one piece. It's like a disc herniation. And the patient was very fine postoperatively. So here, risk of CSF leak, 0. Postoperative outcome for this patient, outcome. Why would I take the risk of an endonasal approach? Meningioma like this, yes, it's an olfactory groove meningioma. It's the same type of cases that you can get with an endoscope with a keyhole approach. It's a little bit far anteriorly, so I had a hard time here getting the piece of the tumor that was at the level of the cribriform plate. But still, also here I used an endoscope to check anteriorly the most anterior aspect of the tumor. I'm running a little bit late. I'm going fast on this video, but post-operative outcome was also perfect in this case. Why, again, would I take the risk of having a CSF leak post-operatively? I think that what you need endonasally here to have a significant exposure, good exposure of the tumor base, it's a bilateral ethmoidectomy. You probably need a nasoseptal flap. All this also has some morbidity. And this was the craniotomy. You see that it's not very big, but still I was able to resect it. So minipterional, I go fast. This is a little bit more anterior case where I was using minipterional. Again, I don't like it so much anymore because you have to go through the temporalis muscle. I just show you rapidly the opening. And I feel that patient complain of pain post-operatively. I don't know if the others have the same experience, but this incision through the muscle, they complain post-op. Compared to the supraorbital, where in the vast majority of cases, there is absolutely zero complaint. Patients don't even feel that they have been operated. So this manipulation of the muscle, this is why I am not using the minipterional so much. Nice craniotomy, nice technique. It's fun to do, but post-operative outcome is not as perfect as with the keyhole approach. Okay. Be careful because some of those meningioma may be related to hormones. Every time I'm talking about skull-based meningioma, I'm talking about hormones. And you have to be careful that those patients are not taking progestative treatments because it can regress spontaneously after discontinuation of the drug. And we have many cases now, even of huge olfactory groove meningioma that decrease in size just because we stopped some progestin treatments such as cyproterone acetate. It's a classic location, tuberculum sellae, for progestin-related meningioma. So thank you very much.
Thank you, Sebastian, for sharing with us your experience and how you evolve over time by coming from transsphenoidal to transcranial approaches, but you compensate the limitation of some transcranial approach with an endoscopic assisted microscopic approach. So it's not time to move to Henri Schroeder talks. It will be my pleasure to listen his talks on the management algorithm of such lesions. Please, Henri.
Michael, thank you for the invitation.
With pleasure. Always a pleasure to listen to you.
But almost everything has already been said, so we can go quickly because time is running out. I just want to give my perspective. We have discussed about endonasal transcranial. There's a trend to more endonasal approaches for tuberculum sellae meningioma because the visual outcome seems to be better, which is at least blamed by many of the surgeons who are doing it. But if you look at these meta-analyses, which have already been shown in the previous talks, is that the gross total resection rate of transcranial approaches is still better with a lower risk of CSF leakage. And there is also a nice review published in 2018. And they found that there is a visual improvement, which was higher with the endonasal approach compared to the transcranial approach, but still a higher leakage rate. And also the same conclusion from Ted Schwartz. He wrote for well-selected cases. There has a better rate of visual improvement, but I think it's very important that we point on selected cases. We have discussed also the many factors which are influencing the approach. For me, it's very important, the skull-base anatomy. This is for me a major fact when I choose which approach should be done. Then the pros also have been discussed. I don't want to repeat that. The cons also, especially higher CSF leakage rate, but also the prolonged nasal care. If you make a transnasal approach, the patients are suffering longer time. They have to clean the nose, they have this discharge, they have frequently they have, at least initially, problems with the smell. So that's why I think that we have to consider really the endonasal approach as causing some problems for the patient. So in my institution for frontoscopes, meningiomas, we're just using 3 approaches. It's a frontolateral approach, a supraorbital, which is simply a minor version of the frontolateral, and the endonasal approach. So if I see this kind of meningioma, you see it goes to the tuberculum sellae also, but this probably is originating from the olfactory groove primarily. When I see these tumors, I think it makes no sense to make an endonasal. Danny Prevedello had recommended to make initially endonasal debulking to decrease the pressure. But I think if you can deal with it with one single surgery, we would do it. We would make a unilateral frontolateral approach. Positioning is very important. The zygoma should be the highest point, and the frontal lobe falls back by gravity. And we make this opening, flush with the skull base. That is very important to avoid retraction. And then we start with opening of the CSF spaces and make a debulking at the base. And you see there's no retraction because of this positioning of the patient. It's a very quick debulking. We save a lot of time. There was a review article from Pittsburgh, and they had an average operation time of 9 hours for these tumors, and 1/3 needs a revision. But here we can dissect very nicely from the optic nerve by manual dissection, preservation of the arachnoid plane if it's preserved. And then what they also blame is with the endonasal approach, they are more radical to take all the bone, but it's not true. We can also drill all the bone from the transcranial approach. We can enter the paranasal sinuses to remove all the tumor. And the advantage what we have is that we have a lot of material to close the defect. So we can harvest the periosteum and we can make a closure which is more robust than with the endonasal approach. And then we have this cosmetic closure, skin incision, and you see very good improvement of the visual field, visual acuity. And we always make an MR image after surgery next day with a T2 weighted imaging to see is there any additional edema from the approach. But if you avoid retraction, you can really get a good achievement in these. And you see, if you take care with the muscle, there is not extensive muscle wasting in most of the cases. What I like to use is what Sebastian already mentioned, the supraorbital approach. For many of the tuberculum sellae meningiomas are small, and we use the eyebrow approach. Again, it's very important to have this positioning of the patient. The zygoma should be the highest point, that the frontal lobe falls back by gravity. We elevate the back about 15 degrees to have a good relaxation of the brain. The incision is in the eyebrow. It's very important to take the inner margin of the bony opening here, and also the orbital protrusions all should be flat to get a good approach, a good visualization to the structures and the depths. So the height should be around 2 centimeters. And then you see when we open the cistern, the brain falls down by gravity and we have a lot of space for retraction. This is one case where we discussed, should we make an endonasal approach or should we make a transcranial? But you see there's a very limited interoptic distance, although the tumor is reaching into the sella. And one point more, you see this is the chiasm stretched over the tumor. So I was afraid when I come from below, I have to pull the tumor down to get this dissection plane if it is adherent. So that's why we make the decision to make an eyebrow approach. And you see here's really a tunnel view, very bad visual acuity. So first step is always I cut the falciform ligament. If the tumor is extending into the canal, I open the canal first, but if it's not, I start with the tumor. And this tumor was very fibrous, so ultrasonic aspiration was not working. And this is the most important step to dissect the small vessels. These vessels are all chiasm supplying vessels, and we have to dissect this arachnoid plane. And this can be done very nicely from a transcranial approach, because in tuberculum sellae meningiomas, we have a post-fixed chiasm. And then I use the endoscope to have a better view in the depths. You see this is pituitary stalk, and this is the origin of the tumor. It comes like a mushroom from the stellar space. And here you see the grooving on the chiasm caused by the pressure of the tumor against the anterior cerebral arteries. So the tumor is dissected from the intracellular space, and we can get a gross total resection. And all done by an eyebrow approach. So the eyebrow approach, for the eyebrow approach, it's very important that you have an endoscopic visualization to look around in the corners, especially beyond the ipsilateral optic nerve. And this is the cosmetic result after 5 days. And you see a rapid improvement already after 3 days. And then, as Sebastian has shown, even if these small eyebrows, we have a very good cosmetic result where the scar is hard to visualize. And after 3 months, normalization of the visual field. And cosmesis is really excellent, but what I think is very important, but what's not mentioned by Sebastian, is that you have to fill these gaps caused by the craniotome, especially in ladies which have a very thin scalp. Otherwise, you see after shrinking of the scar, the outline of the craniotomy. So we always fill it here with bone cement, and then you have a very good cosmetic result. Here's one example. It's a lady you see after surgery. You see the skin suture. I also agree with Sebastian. We should take a suture which is removable. Don't take one where you have to wait for resorption, because this can cause some not nice scar formation. And you see, it's hard to see, even though she has only a very thin eyebrow. And of course, in men with a bald head, the eyebrow incision is really ideal, so nobody can see the surgery. So endonasal approach is also an indication, I think, for me. This paper was already cited, and it differentiated the skull-base anatomy. Is the tumor low rising or high rising? If I would see such a tumor, I think the endonasal approach is much better than the transcranial approach. Especially if you see such kind of very steep tuberculum sellae, then I would always do an endonasal approach if the tumor is midline. Of course, if it's extending laterally, then it's still an indication for transcranial. This was a lesion what we had seen with visual problems on the left eye. You see the compression, the left optic nerve. There was no dura tear, so I was not completely sure is it a meningioma or not, but you see it's also a steep tuberculum sellae. So we made the option for an endonasal approach. I always remove the bony cellar floor to be able to push the pituitary gland a little bit down, coagulation of the superior intercavernous sinus, then opening of the dura, coagulation of the sinus, and then a V-shaped dural incision. And I also agree with Gigi that we have to unroof here the beginning of the optic canal, that we have the carotid. The carotid protuberances were partially removed. And you see the tumor is almost avascular. That is a big advantage because we have destroyed all vasculature by drilling of the skull base. And then, of course, it's easy to dissect if, like in this case, we have this nice arachnoid plane and the tumor comes out very easily. If you do not have this nice plane and all the small perforators are very adherent, then of course, it is a little bit cumbersome to dissect. And here we can resect the tumor. This is a carotid, so we can go very close to the carotid and we can remove all the infiltrated dura on a direct visualization. So it was a small tumors in midline. I think there is still a good indication to make an endonasal approach. So we don't use fat in these cases because it's not a high risk CSF leakage. We just take a little bit duragene and then we take the nasoseptal flap. It's different to craniopharyngiomas, and then in these cases, I always take fat. So, but we have to consider when we look at these tumors, I said that the individual anatomy of the skull base, for me, it's a very important point in the decision making. You see here, it's very flat. So for me, it's ideal to make a transcranial approach. Some people said to me, yeah, we can do it endonasal. It's a small tumor, but I said, no, I want to do it transcranially. And you see the tumor is extending into the right optic canal. And then I always come from the contralateral side because we have a better view to the optic canal. This was a frontolateral approach, and I don't use much coagulation in the beginning, but first I want to have orientation. This is the carotid on the right side, and I dissect the tumor, and then you see here is a vessel, and this vessel is a really big vessel of the superior hypophyseal artery is running into the tumor. It's really within the tumor, and then it was very difficult to dissect it, even though I had a transcranial approach, because the vessel was really within the tumor. There was a good arachnoid plane, but you see we have to dissect very carefully to preserve this vessel. I think it would be very difficult to do that from an endonasal route. It is possible, but I think it's much more cumbersome and there's a higher risk that you make a damage because the vessel was not lifted up by the tumor as it usually is, but the vessel is running exactly through the tumor. And then we have to dissect in this arachnoid plane and dissect this vessel completely away from the tumor. So I was very happy that I made the choice for the transcranial approach finally. And if you see, this is really an anomaly. It's just one vessel. It's a major vessel supplying all the chiasm. And you can imagine if you cut this vessel during the surgery, there was not a second vessel from the other side, then of course you will have a severe visual problem. It's another case, a lady with visual problems on the left eye. And you see this tumor, typical meningioma. Of course, you could make an endonasal approach, but we made a transcranial approach. And you see here, that is what frequently happens with meningioma. They have an unplugged growth lateral to the extension, what you can expect from the MRI. If you make an endonasal approach, you will not see this tumor here on this side. But with a transcranial approach, you can also see this unplugged extension of the tumor, which goes beyond the MRI image. And that's why, again, this is a clear point for the transcranial approach in these lesions. And we made a histological investigation. It was clearly tumor. Another case, 52-year-old female, on both eyes problems. And you see this tumor, you might say, it can also be done endonasally. You see here, there might be a contact between the anterior cerebral arteries, but looks not very problematic. And then during surgery, you see that the adventitia is completely infiltrated by the tumor. So there is really sharp dissection required, by manual dissection required to detach the tumor from the artery. And we had to leave a small piece here in the anterior communicating artery because the tumor was so adherent. So that is a problem which you can expect. You never know it before, and it makes it easier with a transcranial approach. And then there was a paper from Ted Schwartz about here comparison of endoscopic endonasal against the transcranial approach, and they found a very high rate of visual deterioration, 44%, and also a very high rate of seizures, 27%. And we had in the same issue also our paper, and we had no seizures and we had no visual deterioration. Then of course I had to write a letter to the editor, and Ted Schwartz responded that all meta-analysis showed that the visual outcome is better, and he cited his own paper. And if you look at his papers, he wrote finally that there was no significant difference in visual outcome. So I think there is still a debate about what is better, what is not. In my series, we have 26 patients. I had 2 visual worsenings on one eye, but in general, there was a high rate of visual improvement. We could preserve olfaction in all cases. We had just 1 CSF fistula and no infection. And the problem what you can have of visual deterioration is if you try to dissect under the ipsilateral optic nerve, and that is a problem if you use a lateral approach. Michael's approach is midline. He can look to both But if you come from the side, you need an endoscope to look in this area and you can resect without much retraction. But the major problem or the major reason for deterioration, I think, is the growth of the tumor. You see this is a huge tumor, goes bilateral, and you see the calcification. And when we made the surgery, there was no arachnoid plane. The arachnoid plane was completely invaded by the tumor. And you see, this is the superior hypophyseal artery. There's no plane. And initially I was thinking to stop because I thought I make her blind when I sacrificed both superior hypophyseal arteries on both sides. But then it took a long time, I think 9 hours or so, millimeter by millimeter, we resected the tumor with preservation of this vessel. So the growth of the tumor, I think that is a major problem which might cause visual deterioration. It doesn't matter whether you come from below or from above. And finally, she improved a little bit. So my conclusion is that I agree with the paper which was done by the ENS skull-base committee, but I do not agree that the ipsilateral approach is on the side of the worst vision, because I would select the approach on the side contralateral to the invasion of the canal. Of course, if the invasion is on both sides, I would come from the worst eye. So I think I agree with the statements that the transcranial approach is preferred in most of the cases, but it's an individual patient-based decision. And sometimes I see an indication for endonasal endoscopic. Thank you for your attention.
Thank you so much, Henri, for this very great talk. And again, I received some comments. We assisted now again to a very great webinar with great talks of all of you. Thank you so much. I received a question about the access, homolateral or contralateral access to the most compressed optic nerve. You have already given your opinion, Henri. Regarding the anterior interhemispheric approach, in fact, you will have access to both optic nerves, medial parts, medial component in order to the nerve and remove the lesion that extend inside the canal. It is a little more easy for the contralateral optic nerve because you have a perpendicular view, but the decompression of the homolateral optic nerve is quite easy also, quite easy to remove the medial aspect of the tumor to the nerve. But while I will select, in fact, the approach on the left or right side of the forks, depending on the position of the bridging vein. This is the main thing that I look at on the preoperative MR. I would like to make the bone flap, the craniotomy, just above the frontal sinus in order to avoid any transgression, increasing the complication rate. But I will select the approach depending on the bridging vein. And as I started, I can decompress both optic nerves without too much problem, I would say. I would like your opinion also, Sebastian. Homo or contralateral approach?
Me, I think I use the same strategies as Henry. I always use a contralateral approach to the worst optic nerve. I mean, the vast majority of cases.
Luigi, maybe it's not a question for you. You are on the midline as well as me. Your microphone is off, Luigi.
I agree. Contralateral approach, I agree.
Okay, and Daniel Roy in Lausanne, what's your preferred approach? Homo or contralateral? Daniel, are you still there? No?
Yeah, it seems that Daniel is not there.
Daniel has to leave. Okay, no problem at all. Is there any comment that you would like to make now?
I have a question to Luigi. Gigi, have you seen such a tumor, which I showed you in the last case, that there's no plane at all? You see, there's no plane, the arachnoid is invaded. What are you doing from the endonasal approach with these fibrous, very sticky tumors?
We have not necessarily in a very large tumor. We leave remnant. We had similar case with the encasement of some perforating vessel with Eubner and some other perforating vessel. With no plane, we have one more reason to leave a remnant there. when you operate from below. So we try to dissect, but when the tumor is so much attached to the vessel, we prefer to leave tumor there, especially if you are dissecting perforating vessel.
Yeah.
No way. But I don't think that there is big difference with the transcranial approach. You show it that you have to leave remnants or you have difficulty in dissecting tumor without a good arachnoid plane. What do you think? I mean, there are limitations in surgery.
Yeah, but I think it's much easier from transcranial. For example, if there's a vessel injury, I can deal with it very nicely. I can place a suture to close it or so.
But
I would be uncomfortable in an endonasal situation here.
But not on a perforating vessel. I agree for carotid, but not for perforating vessel. If you have injury of perforating vessel, there's no suture or no. Of course, with main vessel, you have more chance to control. This is no matter of discussion on that. Nobody can say anything against this. This is the reason why we have limitation when we operate endonasally. We have some limitation, something that you don't have transcranially when you operate transcranial. But we have limitation concerning the disease. When you don't have arachnoid plane, you don't have.
Yeah.
We are already late. Maybe a final comment, a final word of all of you. One sentence, Sébastien. Something more to say or not?
Great session as usual, Michael. Thank you very much for what you are doing.
Yes, thank you to all of you also.
We are not doing much to
participating
organize it, but you are doing a fantastic job organizing it, bringing us together. Thank you.
Thank you, Sébastien.
Always a pleasure to see you. Always.
It's for me to say.
If Professor Capabianca is there, if he wants to say something, yes, he's there.
I want to congratulate with you. It's a great team. I would like to work with all of you. It's a pleasure to see you in action. It's a great
pleasure to see you. It was a great pleasure to see you as well.
You are good and you're wise. No one of you is fighting against the other. It's very beautiful to watch your way of discussing.
There is no need to fight. We are friends together and we are sharing experience in order to bring the limits more distant from those tumors.
Exactly. There are multiple ways to skin a cat, you know.
Yeah. The only comment I would make, the last comment, the only comment I would make, if anybody should take a tubercular sellae meningioma on me through the nose, it would be Gigi.
But we hope you don't need it.
You never know. You never know.
And the final thing, so I will invite all of you to participate to the next skill-based section webinar, which is planned on January 20. And it will be a very interesting topic as well. It will be on craniopharyngiomas. So I think the team will still be there.
Of course.
I'll be watching you with admiration.
With great pleasure. So I will say good evening to all of you. Thank you for all the people who attended the meeting. We were more than 200 at some point. So it will be a great pleasure to see you the next time. And good evening and have a good end of this year, despite the sanitary condition. Be safe. And it will be a great pleasure to see you in a few weeks.
For you too. Happy holidays.
Happy holidays.
Happy holidays.
Bye-bye.
Bye-bye. See you next time.
Bye.